make sure people back here aren't plain English or what my latest thing is.
So I'm Christina Haygood. I'm a nurse practitioner with the Memory Program. And as I mentioned earlier this morning, I was brought on by the Memory Program to really sort of follow through with the Vermont Alzheimer's and Dementia Care Program. And we just wrapped up a year of the pilot program within the Memory Program in combination with UCLA's model. And it was a nice experiment because it kind of showed us what UCLA is doing through their ADC program. How does that play out in Vermont, and what were some of the challenges and the barriers that we ran into that may be other practices around the country that they might not experience so much trouble with. So I'll go through all of that stuff. Is anybody here doing cognitive screenings? Yeah. Okay. And then, one of the things that's a little bit misleading about sort of the little blurb about what I'm talking on is the main goal of the VADC program is not to screen and diagnose. The main goal of this program is to really focus on the dyad, give them the support and the resources that they need, and also help manage some of the things that may come up as dementia progresses. So I'll go over the program, what it includes, and what we identified in the one-year follow-up, and then I will kind of go into some of the screening so that if anybody is interested in screening, I think that that's a big barrier is kind of like with the Medicare wellness visit, we should be doing cognitive screenings, but what should we be doing, and then what do we do after that? What do we do with those results? Okay. So the ADC model, it was started through a collaboration of the BOLD and the DALE grant in 2024, and that's why I was brought onto the Memory Program. And so you'll see that the goal is really to really help support these dyads and connect them with resources, connect them with support, education. It provides a personalized treatment plan. So we're really doing an in-depth assessment of all of these dyads. We're not just assessing the patient, we're also assessing the caregiver. We're looking at caregiver depression scores. We're looking at caregiver strain. And we are trying to find ways to intervene. And the aim is to address the dementia-related challenges before they arise. And that was one of the challenges that we experienced. And so I began enrolling patients at the Memory Program in June of 2024. And as I said, it's really focused on the dyad. And if we're looking at the way that we differed our program compared to the UCL, the ADC model, their program is really designed to be co-management. And so the way that works is that the primary care provider, the psychiatrist, the neurologist, whoever's doing the diagnosing will refer somebody to the dementia care specialist to do a more thorough assessment of dementia, identify their needs, and then provide specific, personalized individual treatment. So it really is more of co-management as opposed to I'm referring this, you take over them, and you do everything. You do the management, you do everything. So that was one of the things that differed quite a bit between the way UCLA does things and the way we do things, because it was restricted to the Memory Program. I wasn't taking referrals from outside providers. And so we worked very closely with UCLA over the course of a year. They gave us all of the templates that they use for writing notes, and met with them. They audited our notes to making sure that we were staying true to their program. And so you can see how this might differ when somebody walks into a neurologist's office and they either get 30 minutes or 60 minutes, if they're lucky, to go through the diagnosis and the assessment. We get 90 minutes with everybody. It includes a pre-visit assessment, lots of screening tools, and again, focusing on both scoring for depression, patient, caregiver. We're doing a lot more thorough of a neuropsychiatric inventory. Are there already behaviors and mood symptoms present? how severe are they, and I don't know if anybody's familiar with the NPIQ, but it really is good about, are these behaviors present, but is it distressing? So you can have somebody who has hallucinations, but you know what? These kids provide entertainment, they provide company, so we're not really going to do anything about that. So it really does a good job of separating that. And so the way that it differs from sort of the traditional model is, you come into the neurology office or whoever's doing the diagnosis. Here's your diagnosis, we'll start this medication, we'll see you in 6 months. And this really does provide a much more personalized way of assessing, better understanding what their concerns are, what their needs are, and then tailoring the recommendations. And then that also includes tailoring the follow-up intervals. So we do continue to do the cognitive screening every 6 months, but I did pull up, oh no, I can't open it. That's really a shame. Let's see, I wonder if it's because I'm not connected to the internet. I was gonna pull up a copy of the note template that we use. So, if you're looking at a typical office visit note, you're getting the HPI, the subjective, the SOAP history, whatever it is in the note. Usually, it's something that maybe fits in a page. This is the diagnosis, this is the workup, this is the treatment plan. The template that we use for the VADC program is anywhere from like 11 to 14 pages once I finish writing my note. And it's because we are looking at so many different aspects of their life. What's their education level, and that into safety. Are there firearms in the house? Are there falls? Is the patient wandering? It really is going through a much more detailed safety evaluation and looking for ways to intervene. It also goes into quite a bit of advanced directive discussion. Do they have advanced directives? Do they need updating? Do they have a COLS? One of the things that was included in the 4 M's that is added is the what matters most question. And so after we go through all of the screenings to identify potential interventions or treatments, the last question is, what matters to you? Because we can talk about all these things and I can have a list of recommendations and interventions, but if it's something that's not important to that person, then they're not going to be very likely to follow through with it. And so it really is a way of painting a much more detailed, thorough picture of what they're experiencing at home.
Christina, is the what matters most question, is that for the patient and the care partner? Do you ask each of them that?
It's so everything, unless it's specific to, on the paperwork, unless it's specific to the patient, like if, so with the with the patient depression screening, that's completed by the care partner in observance of the person. And so this really is, it encompasses what matters to both of them. And so it's a lot of this, the paperwork we ask the caregivers to fill out, but it is much more encompassing of what both of them are looking for and what both of them are needing. And so sometimes they do separate it out. I mean, the what matters most question, I have to give examples usually because nobody's used to getting asked that question. It's just kind of like, what do you mean what matters most? Like nobody's ever asked me that before. And so I do very specific examples. I want to continue attending church weekly, or going to an important family function, or staying home as long as it's safe and possible. And so I get some really interesting answers on that. But I think it would be interesting to see if everybody started implementing that, because again, we can sit there and we can talk about like, oh, this is what you should do for your blood pressure, this is what you should do. Is it important to them? No, they're not going to do it. So that's kind of the last piece of the puzzle of this 11 to 14 page note is, okay, we have all this information, how can we put that into context of something that's important to these people, and so that they're hopefully more likely to follow through with some of the recommendations. And so something else that we take from all of this information through, do they have advanced care planning, Is it on file? Do they have a pulse? What are the safety recommendations? Some of these things that come up in the initial visit, we started a classification system. So everybody who goes through this program, you get checks and we put you into a green, yellow, or red category. And what we found, because we were doing this before we started the UCLA model, and everybody was like a green or a yellow, basically. We had very few reds, but after doing this more thorough assessment, it shifted. We had, the majority were reds and yellows, and I had very few greens. And the way that changes the way we treat and follow up with the patient is that, so the greens, 6 months, if you need something, we'll contact you in the meantime. Yellows get a follow-up appointment within 3 months, and there's usually some kind of contact in between that. And then the reds, I'm usually seeing them monthly. And I even had some who I was seeing more frequently than that, because by the time they got to me, again, everything was just, I mean, there's just so much work to be done, and they were in such great distress that I was working with people, I still have people that I follow every 3 weeks. Because they're having such a hard time. So that was another thing that sort of differed from the standard model of care, is just being able to see this information and then put them into a category and say, we need to follow this person a lot more closely. So part of what happens after that 90-minute initial visit is we have the recommendations that are broken down into what are the social needs, what are the medication needs, what are the behavioral needs. And a lot of what I did was referring to our social workers within the memory program, and if they weren't eligible for those services, referring them to the Dementia Family Caregiver Center for additional support, caregiver resources, caregiver education. Our social workers in the DFCC, they don't only just do the caregiver support groups, but they also meet with people one-on-one. And so they really have a time set aside that the caregivers do to have their own space where they can just focus on themselves. Sometimes those visits are much more educational in terms of what are some of the symptoms you're noticing with your person that you're caring for. And what are some of the things that we can do so that it doesn't become more problematic, or we can reduce some of the distress, we can reduce some of the anxiety. And so they're working really closely with social workers if they choose to schedule that appointment. I'm also referring to community partners, the area agencies on aging. A lot of the people that I come in contact with that initial visit don't know, so I'm going to speak of Age Well since I'm in Chittenden County. They don't know what they do. They don't know who they are. They don't know how to get in touch with them. And then even after I give them, say, okay, this is kind of your starting point. You're needing help, whether it's getting financial assistance to see if they're eligible for in-home care, or if they're eligible for something that might pay for some home modifications to make things safer. Nobody knows that they do that, and by the time they get to me, it's amazing that most people still haven't heard of it by the time they get to me. Like, how did you get here? How are you here today without some kind of support? So that's one of the things that I do is one of the resources is let's get you in touch with the Agency on Aging. Are there other community partners that we can get you set up with? Just to get you some respite and get you some education and resources. And then I also always refer to the Alzheimer's Association. They have the 24/7 helpline. That's one of my most frequent dot phrase uses because instead of calling instead of calling 911 because somebody's having a really, really significant behavioral episode, instead of calling the police to come and respond, can we get somebody on the phone who is trained in communication and let's talk to them this way and see if it happens, see if we can avoid the paramedics coming to sweep this person off to the emergency department where everything's just going to get even worse. So making sure that they have some of the resources, and also based on some of the behaviors that may be identified on the NPIQ questionnaire and what the caregivers are telling me are the most concerning or distressing symptoms. I might go ahead and refer them to the social worker in DFCC, their teaching cares program, but typically I just try to get them in and just to talk to somebody, just to have that kind of connection, and that kind of immediate I send the referral, DFCC is on the phone with them later that day. That in itself can be so therapeutic to a lot of people, is just, instead of having to wait 2 weeks, 3 weeks to hear from somebody, they get on the phone and they call them and say, hey, I'm here, let's set up something, and just that kind of immediate response is very, very powerful. Yeah, I kind of went off topic there. I don't remember what I was going to say about the behaviors. Depending on if the behaviors are present, it'll come to me later, who knows. And so I do, and again, something that differs from the UCLA model is I think that a lot of their APPs are providing recommendations and sending it back to the referring provider, sending it back to the primary care provider or the neurologist and saying, for these behaviors I'm recommending we do this, 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 and this. But I'm doing all of this stuff. So if medication is needed, if there's danger to self or others, then I'm the one who's doing all of this stuff. So that is a little bit how it differs from the UCLA model. I had it again and then it went away. It'll come back to me again.
Do you prescribe the medications and continue?
Yeah, I'm doing that. Yeah, and so that again is how it differs. And it was really, it's funny because whenever we had these monthly meetings with the UCLA team, they didn't quite understand what we did at the memory program, because they're having to refer out for a lot of the things that we have available to us. Like we have our own in-house neuropsych testing, and we have our own social workers. And so we have a lot of the built-in supports and resources that they're like, how does that work? And so yeah, we did have to tailor it a little bit, but yeah, I take over basically the management of the medications, the dementia-related medications, mood medications, all of that stuff. I was hoping that if I read through this again, it might trigger what I was going to say again, but if it's not that important, it's not that important. Okay, so we did this program. Again, I started enrolling in June. Before I arrived, there was another nurse practitioner who was implementing this program and enrolling patients, so I did inherit some. And then we just ended the data collection. Shannon's here. Shannon is involved in the data collections through the end of September. So the grant ended at the end of September, and so we looked at the data. And we were looking at pre and post scores for anything that we had a pre-score on and comparing it. What we were looking for is, were there changes in the behavioral rate of essentially some of the screening tools, the NPIQ, caregiver strain, depression screenings for both the caregiver and the patient. And so I do have some of that stuff. Our goal, I think, was to enroll, I think it was 125. Does that sound right? Yeah, 125. We only got to 60, and I'll talk about some of the barriers here in a little bit. And then we ended that cycle with 53, and there was a loss, either death of a care partner, people who were transitioned into a facility. There were a couple of people who dropped out because of the location, because of the geography of Vermont and how far people travel to get to us. And essentially, the health started failing so much that they just we couldn't follow them because they were so busy with other appointments with other health conditions. So that's why we had a little bit of loss. We also, once a month, I traveled to Project Independence in Middlebury, which was lovely, and kind of eye-opening, because I think that it really helped expose the folks who were visiting me there to day program. When they have this idea of what an adult day program is going to be, and then they walk into Project Independence, and it's this lovely building, and people are having fun, and there's music, and there's laughter. People will go from, oh, mom will never go to that, absolutely no way, hard no, to, she's having fun here. I think that this might be something that we can actually do. And then also having access to all of their support services within Project Independence. If there was somebody who I was doing an intake on and there were really significant strains in terms of caregiver stress, or there's something else going on that really needed a lot more attention, I was right next door to their social worker. I could send her an email, hey, do you mind spending some time with this person? Or if I had somebody who was getting really agitated, they couldn't sit through the 90-minute appointment, because a lot of the folks that I work with can't sit through a 90-minute appointment. It's like, oh, I hear a game going on. Here's somebody, why don't we go explore the game? So it was really nice to be able to better tailor those appointments, because we were already in that environment. And so we also met with some of the community partners. We went and talked to AgeWell. We visited some memory care facilities, and we really did kind of that allowed us to get a better understanding of what are the supports that we have and what do they do, because I didn't even know. Yeah.
So once a month you were coming to Middlebury to actually meet with these patients for their appointments?
Yeah,
and
so
travel to UVM?
Yeah, and the caveat with that was they all had to already be established within the memory program. But because so many folks get referred to us all over the state, it was really nice just to be like, okay, well, I'm going to be in Middlebury. You don't have to drive all the way up to Colchester this day to come and see me. The downside with this is we did not have that many people who were interested in being seen in that area. And so with the new grant initiatives, we dropped that. I don't go to Middlebury anymore because I'll go into what we're doing and some of the takeaways and what some of the barriers were with me actually seeing more patients and more dyads. We visited home health and hospice, and so the pre-post assessments, I think, are pretty much, Shannon, correct me if I'm wrong, they're pretty much in line with what UCLA has noticed in terms of, are the depression scores getting better? Not really. Are the behavior scores getting better? Not really. But caregivers felt more like they could do it. The self-efficacy scores went way up, and overall patients and caregivers were very happy with the amount of detailed care and tailored care that the program involved versus the we'll see in 6-month model. So some of the barriers that I don't know that other practices around the country are encountering because of the way that our practice and referral system is set up, and then also just the rural nature of the state and how fragmented care is and how challenging it is to even get a PCP for a lot of Vermonters. And then how are they going to get there because, it's an hour drive and it's snowing. So I think that the way the program worked for us compared to in Southern California, where you have huge medical complexes, they have no issue getting people into adult day. I almost don't even talk about adult day for my Chittenden County people, because it's either you're going to have to go to St. Albans, oh wait, they have a wait list now, or you can get on the bus to go to Project Independence. And so they don't have as many restrictions in accessibility to respite and resources, just because of their location and their access to resources compared to what we have here. So one of the biggest barriers was the VADC model, the UCLA model, does not focus on diagnosis. And the memory program, the vast majority of the referrals that we get, which is how I was getting my referrals, they don't have a diagnosis. And so it's really just, by the time somebody is showing symptoms, and then by the time they can convince, the care partners can convince their, the person to go get evaluated, and then, are they even being screened? Because then they come to us, they just get referred to us, and there's no diagnosis. And so they're really coming to us for the diagnosis. And this is just kind of I don't know what some of the reasons are. I imagine, having worked in primary care, it really is, it's a lot to put on primary care providers to do the screening and to do the diagnosis. But we get a lot of referrals from all over the state and in New York, and it's mostly people who don't have a diagnosis. So in looking at that, and okay, why didn't I get to 125 people? And what can we do about that? And it really is, we're going to try to refocus to earlier screening and diagnosis outside of the memory program, not depending on the memory program to do the workup and do the diagnosis and do the treatment, unless there are indications for it. So with the delay in diagnosis, as you can imagine, people are just chugging, they're having to figure out everything on their own. Oh, is this normal? I don't know. Is this normal? What do I do about this? Who do I call for this? And so by the time they got to me, a lot of the patients were already in the moderate severe dementia stages. And if you can imagine the amount of caregiver strain that, somebody's been going through it and dealing with the day-to-day, trying to manage their own health conditions, trying to manage their own mental health conditions, while also trying to figure out, what do I do for this person who's keeps leaving the house because they want to go to work. It's time to go to work. And so the levels of caregiver stress and strain were already so high. There were already behaviors present. There were already mood symptoms present by the time they got to me. And that was one of the biggest takeaways is with the way this was set up, we're just not getting to people soon enough. It needs to be earlier in order for us to prevent the symptoms associated with dementia. We have to actually get to them sooner before they develop. So let's see here. The co-management model also was a barrier, I think, because again, when we get referrals to the memory program, it is, this person has memory complaints, you take care of it, take care of it. And it's not the model that is intended to be the UCLA model, where here are the recommendations and they're really keeping the care within the main hub. Our system just doesn't work that way. We get referrals and they don't manage the dementia, they don't manage the mood, they don't do a lot of that stuff. And I'm not, this is like, that's a gross overgeneralization. I'm not saying that nobody does that, but from the referrals we get. Because I know that there are providers out there who are managing their own patients with dementia. We just don't see them because we don't get the referrals. Let's see. Okay, so the other limitations, they had to live at home and they had to have a caregiver. And this was tricky because a lot of the folks that we see, not a lot, many of the folks that we see are still living at home alone. They don't have a caregiver. And so I did start to open it up to people who were still living alone, but they had family who would maybe come and check on them. Just to see if we could help provide more wraparound services and safety net for this person who has a diagnosis of dementia and they're living at home alone. And
Christina, so you initially defined caregiver as someone living with the person?
That is, so not necessarily the way that we carried it out. But they just had to have a caregiver, a family member or a friend, somebody who was providing direct care with them. And we did start off as, do they have a living caregiver? But no. People started getting referred to me because this person's living alone. And nobody's there overseeing their medication. Nobody's actually there in the house, but this person needs more help. So it evolved to include that.
So this person has to be unpaid, they can't be paid like a home health provider as a caregiver?
Correct, yeah, that's what it was designed for. I did, there was one person I got referred who had 24/7 hired, paid live-in care. I'm like, what do you got a lot of support, that was interesting. But yes, it is generally for the unpaid. It is somebody who, family, friends, people who are not getting paid, who are experiencing the caregiver burden and the caregiver strain and the caregiver depression because of what they're doing without pay. You know? So that was a barrier, I think, to enrollment, and then also that excluded people who were already living in memory care. Continuity of care and administrative barriers. And so we were limited to enrolling people who were already within the EPIC system. We already needed to be able to see all of their records and to be able to provide recommendations. And then we also had some stuff just with the finances and the funding. There was a lot of kind of like, oh, this is, you know, extra work for us if we're having to enroll these extra, like, you're not really, there was some pushback, but also it was requiring a little bit more time and resources from within the memory program. So that's when I say administrative. And then also administrative is, you know, if we wanted to open up the program to, you know, outside of the memory program and start taking outside referrals, well, we have a year-long wait list to be seen at the memory program. So what do we do with folks who are just getting referred to that, and then we run out of grant funding money? Do they go back to the back end of the referral line, or do we go take them back to the primary care provider? How does this work if if the grant funding isn't extended? And I think that, you know, it kind of goes without saying, but I'll reiterate it all again. Everybody who would have benefited from earlier interventions, treatment, education, I mean, it was a referral to the program too late. I mean, it's never too late, but like, it kind of was. And yeah, they weren't aware of the resources, they weren't aware of the education, they really had no one to turn to. Yes, caregivers are overwhelmed. They would come to me, and sometimes 90 minutes is not long enough to spend with people, to really sit down and give them the space to be heard. And it's really challenging to sit down with somebody and say, well, you have advanced directives. They were completed 15 years ago when the husband was the medical power of attorney. He's been dead for 10 years. This needs to be updated, but they can't sit down for long enough to, you know, complete some paperwork because they're trying to, you know, manage the house and like, oh, they're running out the door again, gotta go get them. You know, it's trying to implement any kind of education or recommendations to someone who essentially, it's like the house is on fire and you're giving them like a little garden hose and say, oh, can you just, you know, fill out this form too? While you're at it, it's just, I mean, the overwhelm is so great that a lot of the education and resources and additional appointments and additional follow-up is really just, it's just another thing that they have to do. It's just giving them another thing that we have to do on the to-do list. Again, yeah, they lack the time, energy, and resources to, I know you referred me to the social worker. I know that it could help me. I don't have time. I've got my own medical appointments and my own issues going on. I don't know how I'm going to fit this in. And then, yeah, the big thing, we identify the needs. You need help. You need help in the home. You're trying to manage your cooking and your cleaning and the medications, and like this person, you know, is trying to, you know, beat you up while you're trying to get them in the shower. It's people who need help and they need connection with day programs. They need connection with, you know, somebody who can come and take on some of the personal care that's required to continue to keep somebody in the home. And most people don't qualify. They're in that position where they either, you know, they can get on Medicaid, and I did have one really good success story of somebody, one of my frontotemporal patients, who was just like, she was climbing over fences. She's young, so she's climbing over fences, she's running everywhere. We were able to get them qualified for Medicaid and 40 hours of the same caregiver. I see her like every 3 to 6 months now, and that was like I was seeing her every 1 to 2 weeks initially. And so that's just having somebody who's in the house for 40 hours a week so that the husband can go attend to his own things, and somebody that has a rapport with my patient and knows how to respond to her behaviors. They don't call the office. I don't really see them anymore. But the majority of folks that I work with are in that category where they don't qualify for paid services, and paying for anybody out of pocket is so far out of the realm of what they can do. They basically just continue to suffer through it. And I think that there also is, I think I touched on this earlier, but there is just a lack of understanding about what the resources are that can help you and what do they do. So like an example is I would tell somebody, well, why don't you call AgeWell and they can run the finances, see if you're eligible for any kind of grants or support service. But they don't know what to ask, and they don't know what they do, and so they say, well, I met with them a few years ago, and they just came and they gave me a piece of paper with some stuff on it, and then that was it. So I don't know if I really want to call them and say, okay, you need to talk to an options counselor. You need to see what your options are and what you could benefit from. So giving them very specific language of, I want you to call this number, and this is what you ask for. So there's still just a lot of misunderstanding and lack of knowledge about what is available to us here in Vermont, how can it help us. And so after we finished the year, I have moved, much more into a standard clinical role, but then I'm also spending time with the state to work on some future goals to see where we're going. And essentially taking all that information that we learned, the barriers and the challenges that we ran into, and trying to find ways to explore solutions. One of the things that we're doing is trying to focus on earlier diagnosis within the primary care clinics. And this goes back into the screening. A Medicare wellness visit includes a cognitive screening. Okay, what are we doing with the screenings? What screenings are they using, and then what do they do with that information? And are people even getting these things? Because the patient thinks they're pointless, the provider thinks they're pointless, so is anybody actually doing them? And then there's no framework for this is what we recommend you do, and then if it's abnormal, here's what you follow up, and here's what you do with that information. So we're going to be promoting if anybody's in Epic and let's say you get an abnormal cognitive screening, you can pull up, or somebody comes in specifically for memory concerns, it's this .dementia DX, and it pulls up all the questions for different types of dementia. What are their risk factors? What do we think is going on? What is the recommended imaging? What lab work do I need to get? And then what do we do with that information? All of that's pre-populated.
That's awesome. Are you might have said this, but are you going like educating all the time?
That's the goal.
Awesome.
If you know somebody who wants it, I'll do it.
Yeah,
okay. You're at UVM? Or
We work at Community Health, and
Oh,
I was
yeah.
just thinking, if you ever did like a lunchtime
Yeah.
presentation for our providers, they would love it. And,
Yeah.
like they do a lot of the cognitive screens, but then the MOCA's positive, there's something going on, and then we refer to UVM, and then
Yeah.
wait like over a year,
Yep.
and the patient declines. So
Yeah.
it's exactly. But I think the providers would be happy to implement more, but need a bit more.
they need guidance.
Guidance,
Yeah, because
yeah.
even, before I sort of went into neurology specialty, even though I was in geriatric primary care, it was kind of okay, do I know everything? Could I just list all the things that I need to do with this abnormal screening? No, I couldn't do it. And it's very just kind of piecing things together. And I think I got to do this, and I think so. This is something that provides more structure and recommendations for helping PCPs to diagnose, or at least do some kind of follow-up with the screenings if they're abnormal.
Do you recommend, I know each kind of screening tool has a slightly different purpose, for example, MMSE versus MOCA, but I work for long-term care Medicaid, and one of the nurses that assesses people for long-term care Medicaid eligibility, and we've been going back and forth on what are the PCPs using, what should they be using, is
I'll
there
get
something,
into that.
okay, perfect, yay, because we want to be in alignment with them.
Yeah.
So that way, when we're getting medical information or sending them information, that we're kind of using the same information or
Yeah.
tools, right?
Yeah,
Yeah.
yeah. I'm going to get into that.
Thank you.
And so we're going to be working not only on helping to educate primary care providers of what do you do after you get an abnormal screening, how do you do the screening, what do you do, and then what do you do with that, but also you get a positive screening, and there's also collateral from the caregiver of like, yeah, things are a mess at home. I don't know what I'm doing. Well, instead of just referring to the memory program and then they sit for a year, sometimes longer, and then they get connected with the Dementia Family Caregiver Center, that's a resource that all Vermonters are eligible for. I don't think anybody knows that. So if somebody...
So we're care coordinators, so we do a lot of referring to agencies, and neither of us have heard of
Right?
care managers.
Right?
I hadn't heard of
Yeah.
that.
Even whenever I started at the memory program, it was kind of like this, oh yeah, there's the DSCC.
And I like to think that we're pretty well knowledgeable.
Yeah, and so most of the folks who come through the memory program get sent to our social workers within the memory program, because the DSCC really is kind of like a separate entity, even though
Is it
we're...
part of UVM?
It is, yeah,
But
yeah.
anyone can access it?
Yep.
Okay.
Yeah, and so this is something that we want to promote.
And
Don't
that's
wait.
where the teach and the carers?
Mhm.
Okay, so we
Yeah,
do know about
okay.
those. So
Yeah,
that's
teach
easy.
caregivers, but they also can meet with people one-on-one and individually and say, you know what, these are the things that we should focus on, and what are you doing to care for yourself? So they work in the structured programs, but also in just more of a therapeutic therapy type relationship with our caregivers. And so that's one of the goals that we're working on, is let's promote these services and these support systems before or earlier, once problems are identified, let's go ahead and send them resources and support so they can get education, so that, when the mid stages, moderate to severe stages, if there's hallucinations or delusions, it's not like, how did this happen? It's people would get to me and say, no one explained, such and such and such to me. And so one of the needs that was identified is just like, they want not just education, but they want specifics. They want to know, what can I expect with this disease at different stages, and then what can I do? What are some very specific things that I can do at home to help with this?
Yeah.
Because I would give them a list of, the person's wandering, well, how about we just install like a door alarm, so that at least you get alerted if they try to go to the door. I can't recommend a specific door alarm, so here is, this is what you want to Google. And then adding that to their to-do list. And so I see them for a follow-up in a month, and it's like, oh no, I haven't had a chance to look at that stuff.
Do you ever refer back to the care management with it? Like, I work for UVM Population Health Service Organization, and each of the UVM practices has a care manager there.
Uh-huh.
Do you ever refer back to them to help carry out
I do actually,
Good.
yeah,
Awesome.
yeah. There are some PCPs that I work pretty closely with, who have sent me some really lovely patients with some severe behavioral symptoms. And so for those folks, I do like to check back in with a PCP, because our social workers won't sit down and do the paperwork for Medicaid with them. So it's they need somebody to walk them through this stuff, and that's not really the focus of what our social workers do, so let's get them connected with somebody else who can help them with that. And then promoting that we have enhanced consults. If there's something where you think you might have a clinical question, you think you have everything sorted out, but this is kind of throwing me off, or I need some help looking at this imaging, but otherwise, I'll continue to diagnose and manage the patient. Usage of the e-consult, trying to help reduce our wait time so that. And I'm not saying that the 85-year-old with classic dementia doesn't deserve to come to the memory program, but the 59-year-old who could benefit from biomarker testing and infusions and more advanced treatment, they're sitting through that same year long. We're losing
You guys
time.
don't triage the referrals?
We have a triage referral system. I don't know how well that's actually done though. And so because we have so many referrals, it's really hard for us to even sort through them all to triage them. So yes, there is a system, but because of the overwhelm, it's just, I don't know how early some of the earlier onset folks are getting detected. So I'm going to be promoting that, and then also hopefully creating a list of resources and education that can remain within the primary care clinic of like, you know what, this is your diagnosis, this is what I'm going to treat you with, or this is the medication we're going to prescribe, and then here's a list of resources. Instead of them waiting to get to us to get the resources, why can't it be done earlier? Yeah, and I also, I think that there needs to be connection within the providers and within the service providers. I think, correct me if I'm wrong, but the agencies on aging, they don't really have the same kind of protocol systems. Like all the agencies on aging, they differ pretty greatly based on where you are in the state. And so we need.
Well, I'll argue with that.
Yeah,
We don't differ. I was saying that earlier. We work very hard so that if you come to any one of our programs, you're going to get pretty consistent services. So I'm not sure what the I mean, we're all independent agencies.
Yeah.
So
that's, I think what I mean is that the independent. So, but is there like do you meet with each other?
Absolutely. We have an association. We recently formed a consortium to further consolidate our services and unify them. Our case management team is getting across the state the national certification of case management.
Fabulous.
So we're absolutely working on anywhere you go, you're going to get the same quality services.
Fabulous, because I was told otherwise, and this also connects to the disconnection and the fragmentation of nobody understands what anybody else is doing.
Right.
I don't want to, I'm going to contradict you a little bit, Mark. So I work with A12, and I'm part of the caregiver support team. And, so we are doing a lot in terms of, finding common ground and, setting benchmarks across the state for kind of how we work. I don't think we're there yet.
Sure.
In terms of caregiver support. I think in terms of case management, I think things may be different. But certainly, there are significant differences. I'm just the practitioner, right? So there's significant differences between what my day job looks like and what the day job of a family caregiver support specialist at some of the other AAAs looks like.
Yeah.
So a lot of
there is
them work
a
right
little bit of that.
between two of the agencies, so we work very frequently with Angel and with SVCOA, because we're right smack dab in the middle. And there are significant differences in what's available, just some of the different resources that one has versus the other, and I don't think that's, it's just the area, the service area.
Yeah.
Even sometimes how we refer
Like
is
funding
different.
streams.
And that's a part of just an economy of scale.
Yeah.
Age well covers a bigger area. They have just many more resources than if you go to Northeast Kingdom. Northeast Kingdom just isn't going to have the resources and the workforce. So sure, on the ground there are certainly differences in what we can provide, but overall we try to cover the bases.
I think we're all facing the same way.
Yeah.
Yes.
I mean, it sounds like you all have options counselors, you have case management, like there's basic structural stuff that you all align with, right? But it's like some have dementia respite grants and others don't, right? Some have a more robust family caregiver program and others, right? So it's
So that is kind of, taking that information from the first year, from the findings, and what can we do? How can we tweak the program to better fit Vermonters? I'm not going to go too much into this. We already know that. So when should we screen? A Medicare wellness visit, when you suspect cognitive impairment or decline, or when somebody voices concern. And basically anybody who's trained to use these screening tools can screen. And I think that, with some of the more advanced ones like the MOCA, it really does, there's some nuances to administering something like that unless you're trained. But there are some very, very basic ones that basically anyone who's familiar with it can do. So we typically do the MMSE. The reason that we don't do the MOCA is because the MOCA is more sensitive for mild cognitive impairment. Most of the folks that I work with are way beyond that. The MOCA really is a longer test to administer. It's very, very good for somebody who's in primary care and maybe they are doing a screening. And you might suspect there's a little bit of loss. This one will detect better, do a better job at detecting for MCI. It does take longer. So that's why one of the tests, it's not just the MMSE that we do it in combination with other cognitive testing. But this is kind of like the basic one that all of my BADC people get because it's pretty fast, it's pretty easy. The caveat, it's going to miss MCI. So if you're doing a more broad generalized screening, it's not going to detect those. And also, it's not really adjusted so much for education versus the MOCA.
Christina, is there any language that, if I'm suggesting that a caregiver, kind of helps their person to get an assessment, is there any language that should be used that would prompt the PCP to, do we just ask for a cognitive assessment?
It's very personalized, and it depends on their relationship, their history, their communication. So I have some people who are just very out and open because that's the kind of relationship they have, and then I have other people who, especially in the past when I was working in primary care, I get a note before the appointment and say, hey, can you go ahead? I'm having some concerns, but I don't really want to talk about it. And so it depends on what's appropriate for them and what kind of communication they're comfortable with.
But to trigger, however it's delivered, to trigger the provider to do some kind of assessment, is there any language that would trigger that, whether it's in a note or in the visit, or does someone just rock up and say, I'm concerned about my memory, and the provider would say, let's do this. Yeah,
and I think that it's not always that simple because most people aren't going to come to you and say, I'm worried about my memory. It really does take the relationship of the provider and the patient into account. Like I can remember, okay, well, you're not refilling this medication. I didn't stop this medication. What's going on? And then it might not be an automatic, because I think that's one of the barriers with primary care providers doing these cognitive screenings and doing the diagnosis is they have this relationship that they've established over the course of many, many, many years oftentimes. And it is for some reason, it's very, very touchy. It's like, okay, I'm okay telling this person you have prostate cancer, but I'm concerned about your memory. Maybe we should do a little bit more education, or maybe we should do a little bit more testing and just to evaluate, make sure everything's okay. It's sort of this taboo.
Yeah, so in our primary care office, I find both that, the taboo, and the providers not wanting to kind of ruin their rapport with a patient based on it, but then also a lot of patients who don't have the long-standing history with our PCPs can hide it very well. And we'll refer people, we recently had a patient we referred to neurology in Rutland for memory, and came out of the appointment with a no memory concerns, and this patient has severe memory concerns on our side. So it's just interesting how a one-time visit can miss so much.
Yeah, and I think that just goes into put the human back in healthcare. You have to have the relationship, you have to get to know the person, you have to have that kind of rapport, because they're not always going to come right to you. So the best screening tool is the one that you'll use and the one that you're comfortable using. The one that I would recommend to anybody who is not really interested in advanced, learning how to do the MOCA or the MMSE or whatever it is, the state of Vermont has their own Vermont mini-cog. It takes a matter of minutes to administer this. It's very, very simple. 3-word recall, the clock draw, and verbal fluency. They have, the link does not work, I can't, but they have their own website. There's a YouTube video from Vermont, from the state of Vermont. If you just Google, or if you search on YouTube Vermont mini-cog, there is a short training on this is how you do it and this is how you interpret the results. So this, I think, for most people who are short on time, the Vermont Mini-Cog. It's a great place to start. Important thing to know is that positive screening does not mean that they have a diagnosis, because we always have to rule out all of the underlying things. Then that's where some of the other screenings come into play, like substance use screening, depression and anxiety. Are they having, do they have untreated sleep apnea? Are there medications? Looking at the Beers list. Oxybutynin is like one of the big ones that we get people, and like we pull them off of it and it's like, oh, you're back to thinking. So not that they don't think. So this is kind of the basic that we recommend is, you want to do your history in a physical, you want to do your lab results and a CT scan or an MRI, which MRI is typically usually preferred, but CT scan is fine if there's nothing else available. And then the neuropsych testing, I say it's helpful, but it's not always necessary, as are the biomarkers, because the neuropsych testing is a battery of questions. I mean, it is sometimes up to 3 hours, 90 minutes at the best, but sometimes up to 3 hours. It's a lot to put people through if they don't actually need it. If it's pretty clear that it's like, okay, this is definitely dementia, we think it's Alzheimer's. But for those who are like, okay, it's still a little muddy, is this depression that's creating the cognitive impairment, or is it something else? And so there are people who do absolutely benefit from the neuropsych testing, but if it's not available to you and it's pretty obvious that it's pretty crystal clear, then it's not something you really need to refer out to. Biomarkers are the same. Do we think that if this person has a positive biomarker, is it going to change the treatment plan? If it's an earlier or younger person who is like physically fit, I mean, they're out, they're 75 years old, they're out skiing, all this stuff. Very, very active and physically healthy. Are they eligible for some of these more advanced treatments like lecanemab? Biomarkers can be helpful just to be able to get a more crystal clear diagnosis. Is this Alzheimer's, which right now is the one diagnosis that is approved for lecanemab and some of these more advanced treatments. This kind of just breaks down, I think we're going to run out of time. So it breaks down sort of like the things to pay attention to: cognition, what's their memory like, are they having trouble managing their ADLs, mood symptoms, are they present, and then has their gait changed, has their handwriting changed, has anything physically, their motor symptoms changed. So those are things that we really want to pay attention to. I'm not going to go through DSM stuff. So another thing, so in addition to the Dementia DX, the Alzheimer's Association has fantastic, basically a guide for providers. You have a positive cognitive screening. There's something abnormal here. They actually have, if you don't have access to the Dementia DX tool, they have a list of resources for, okay, PCP, whoever's doing the workup, these are the things you need to order, this is what you need to do next. So there are resources out there. There are also, if we're looking at, is this Alzheimer's or Lewy body or FTD, if we're trying to get like very, very specific, most of the, like the organizations like I think it's the Lewy body National Organization, they all have their own little checklists too. So there are some resources where, if you can't get a referral or you need answers faster. And then the referral, when is it absolutely, something that you should jump on? Young, or, abnormal symptoms, sort of like something that's outside of the norm, rapidly progressing, or you're starting to see some really abnormal neurological signs. Big question that I get, what's the difference between the major dementia and MCI? Major's major, and mild is mild. So mild, you really you're still able to do your ADLs, but it's still noticeable to other people. It's still, I like this, because it kind of, so where people come to me is they're usually like somewhere between here and here as opposed to there. And this is when we're starting to see like, okay, they're needing help with, picking out their clothes. They come to the office and their clothes are on backwards or they're not appropriately dressed. I think we're out of time. So
You said your grant ended.
well, so that iteration of the grant ended.
Okay.
So the pilot program based on the UCLA system of care, that ended, and so now I'm working with the state to sort of get a better understanding of what worked, what didn't, what can we implement, and how can we do more of this, have more dementia care specialists around Vermont. So the grant didn't end, but that iteration of the pilot program did end.
Okay.
The other thing that the biggest misconception that I deal with, and this is even from referring providers, is that the medications that we have, like, donepezil and memantine, they don't do anything, so let's just not bother. But we know that especially for Alzheimer's, earlier initiation can actually help prevent some of the behavioral symptoms down the line. And so I still get people who come to me and say, oh, my primary took me off of that medication because they said I wasn't doing anything. But whenever we stop them on somebody who is, yes, they're continuing to decline because the symptoms are catching up with the disease. The disease continues to progress with these medications, but the symptom progression is typically slowed down a little bit by these medications. But when we stop them, there is a precipitous decline in their ability to function, their cognition. And if we restart these, we don't get that back. It's not like if somebody, I want to do a trial off of your SSRI, I don't think you really need it. Oh, no, you definitely need it, restart it back. It's fine, everything's fine. But when we stop these memory-specific medications, we know that they're doing something because oftentimes they tank after we take them off. So.
And you can't go back.
If anyone has any questions, reach out to me. That's about it. I think that's... Yeah, and then depression and anxiety, that is super important because we still get referrals to the memory program where it's like, this person's depressed. They don't have any kind of cognitive, neurodegenerative cognitive disorder. They're depressed. So, yeah, that's it. Questions?
We would love to get in touch with you.
Yes, my name, Christina with a CH, .Haygood,
Okay.
HAGOOD, @uvmhealth.org.
Thank you.
Christina, CHRISTINA, HAGOOD.
Okay. Thank you very much.
Thank you.